Hi everyone, my name is Elizabeth Williams, and today I will be presenting about the drug oxycodone. Oxycodone is a semi-synthetic opioid that was derived from the opioid alkaloid thebaine in 1916. Germany was the first country to use oxycodone in clinical practice in 1917, and the United States didn't make it available for use until 1938, more than 20 years later. There are many different forms of oxycodone, but the most popular being prescription pills or tablets. The controlled-release tablets of oxycodone were approved in 1995 and launched for use in 1996. But since they have been released for use, there has been a large increase in global oxycodone consumption. Opioid prescriptions have skyrocketed so much that from 2000 to 2009, the number of prescriptions per 100 persons has increased by 35.2%. The trouble with prescription opioids is the possibility of abuse. More and more individuals are getting addicted to prescription opioids such as oxycodone, and it has even gotten to the point where opioid analgesics are currently the cause of more overdose deaths nationwide than heroin and cocaine combined. A more recent survey, conducted in 2015 by the National Survey on Drug Use and Health, revealed that in the USA, approximately 27.9 million people aged 12 or older use oxycodone products, and from this, 4.3 million people aged 12 or older reported misusing these products in the past year. While oxycodone is very beneficial for pain relief, it has a high propensity for abuse and has turned into a drug that is illegally sold on the black market in schools and from patients who have prescriptions. In regards to the pharmacokinetics of oxycodone, oxycodone's chemical structure can be seen in the picture on the right. The full name of its chemical formula is 6-deoxy 7,8-dehydro 14-hydroxy 3-O-methyl 6-oxymorphine, and its structure consists of 2 planar and 2 aliphatic rings. Specifically for oxycodone pills, there are 2 phases involved in the release and the absorption of oxycodone. The first phase of absorption involves gastrointestinal secretions disintegrating the tablet surface, which allows for a fast release of the opioid. The effects of this initial reaction occur within an hour of taking the tablet. There is then a second phase of sustained release, which can last 12 hours after ingestion. Once absorption has occurred, oxycodone is distributed to skeletal muscle, liver, intestinal tract, lungs, spleen, and the brain. Oxycodone's main site of analgesic action is in the central nervous system, the brain, and the spinal cord. This occurs mainly due to oxycodone's ability to be actively transferred through the blood-brain barrier. The liver then metabolizes oxycodone into 2 metabolites. The enzyme CYP3A4 metabolizes oxycodone into noroxycodone via N-demethylation, while the enzyme CYP2D6 metabolizes oxycodone into oxymorphone via O-demethylation. These 2 metabolites are further metabolized into noroxymorphone. All these metabolites are excreted primarily through the kidney and in the consumer's urine. But while they are primarily excreted by the kidney, there is a high percentage of drugs that remain outside the vascular compartments, which is another reason for oxycodone's slow release. The elimination half-life of oxycodone varies slightly depending on the route of administration. For IV, intravenous administration, the half-life is 3 hours, while for intramuscular administration, the half-life is 4.9 hours. Additionally, for oxycodone oral liquid, the half-life is 5.1 hours, and for oral administration of oxycodone immediate release capsules, the half-life is 3.8 hours. The elimination half-life of oxycodone has been investigated in many studies. I found a study conducted in 1991 that was performed to investigate the pharmacokinetics of oxycodone after intravenous injection on young adults ages 19 to 37. Oxycodone was administered 13 hours after minor abdominal surgery, and their blood was sampled 2, 3, 4, 5, 6, and 12 hours after administration. They found that the average elimination half-life of oxycodone via IV for these individuals was 3.7 hours, which is a longer elimination half-life than what is reported for morphine. The half-life from this study corresponds with the half-life of IV administration of oxycodone that was stated in the last slide, with a difference of only 0.7. The one implication of this study is that it was performed in the 90s, which is when most of the basic oxycodone pharmacokinetic data is from, which makes the validity of these results questionable as it's not up to date. Moving on to the pharmacodynamics and mechanisms of action, oxycodone is considered a full opioid agonist that binds to the mu, kappa, and delta receptors that are coupled to G protein. While it can bind to all these receptors, it is relatively selective for the mu-opioid receptor. These G proteins are distributed by the central, peripheral, and autonomic nervous system, which is why oxycodone has such widespread effects. When oxycodone binds to the opioid receptors on the G proteins, it stimulates the exchange of guanosine 5-triphosphate for guanosine 5-diphosphate on the G protein complex. Because of this, the adenyl cyclase system is inhibited, which prevents cyclic adenosine monophosphate from being produced. Additionally, there is a fall in ionic calcium entering the cell, as well as an increase in potassium ion flow. Furthermore, there's a reduction in the release of neurotransmitters, which reduces the transmission of nerve stimulation. Oxycodone induces pharmacological effects that include analgesia, euphoria, and the feeling of relaxation. The adverse side effects, however, can include respiratory depression, constipation, cough, suppression, and sedation. There are many effects that high usage of oxycodone can have on somebody, and many factors that can contribute to oxycodone's addictive properties. One of the G protein coupled receptors, the mu-opioid receptor, is found throughout the mesolimbic system. This regulates dopamine release in the nucleus accumbens, which affects responses to drug reward. Opioids act on the mesolimbic dopamine system through inhibition of GABA interneurons in the ventral tegmental area. This exerts an inhibitory control on dopamine neurons in the nucleus accumbens. Thus, opioids indirectly activate the dopamine system through GABA inhibition. Chronic exposure to oxycodone can also produce structural and functional changes in regions of the brain. These regions mediate affect, impulse, reward, and motivation, which are all dysregulated in addiction. It was found that in prescription opioid-dependent subjects, where oxycodone was the commonly consumed prescription opioid in the last 30 days, there was a significant volumetric loss in the amygdala and decreased anisotropy in axonal, efferent, and afferent pathways of the amygdala. Additionally, a decreased functional connectivity in the brain networks in the anterior insula, amygdala, and nucleus accumbens was observed. There are many further directions involved with oxycodone. First off, more studies on the pharmacology of oxycodone need to be performed, specifically on the distribution of it, as most of the pharmacological data is from the 90s. There also needs to be more research and regulations regarding prescription opioids and data on prescriptions. As prescription rates keep rising and addiction rates increase, it is vital that there is oversight and regulation regarding oxycodone and other opioids. As oxycodone keeps rising, more laws are being created to regulate illegal use. Many states are cracking down on this, and there have been many court cases charging individuals with the illegal distribution and use of oxycodone. As mentioned earlier, there are many routes of administration for oxycodone, which can be dependent on many various factors. Differences in routes of administration can be seen specifically between urban and rural users of oxycodone. A study conducted in Kentucky involving 212 prescription drug users from Royal Appalachian County and the major metropolitan area evaluated this. Participants were given an interviewer-administered questionnaire examining socio-demographic, psychiatric disorders, and self-reported non-medical use and route of administration for multiple prescription drugs, including oxycodone. They found that for urban participants, oral use, which includes chewing and swallowing, was the most common route of administration. In rural users, they found snorting was the most frequent route of administration for hydrocodone, methadone, oxycontin, and oxycodone, while injection was the most common for hydromorphone and morphine. After conducting an analysis of age, gender, and race, they also found that rural participants had higher odds of snorting hydrocodone, oxycontin, and oxycodone than urban participants. This study discovered that alternative routes of administration were much more common in rural drug users, which could result in a higher frequency and severity of drug problems and abuse in those areas. The one limitation of this study is that the sample size is only 212 users, and all the participants are also from Kentucky. To gather more evidence and support the results, they should further their research in other states and try to get a larger sample size. Doing this would provide more accuracy in their results and allow for a more dependable study on the different routes of administration between rural and urban users. Another study I evaluated was a study conducted to evaluate whether controlled-release oxycodone tablets or immediate-release oxycodone was more effective in patients with chronic cancer pain. This study was a multi-center, randomized, double-blind, parallel group study performed on 111 patients recruited from 15 different centers around the United States. For this study, these patients received 30 milligrams of controlled-release oxycodone every 12 hours, or they received 15 milligrams of immediate-release oxycodone 4 times a day for 5 days using a double dummy technique. For each treatment group, the total daily oxycodone dosage was 60 milligrams. These patients then evaluated pain intensity and acceptability of current therapy at baseline and over the past day. During the double-blind period, patients rated pain intensity in a diary 4 times a day. They did this in the morning, midday, in the evening, and around bedtime. For these ratings, they had to use a 4-point categorical scale, 0 being no pain, 1 being slight pain, 2 being moderate pain, and 3 was severe pain. They discovered that over the 5-day time frame, the overall mean pain intensity score was 1.4 for patients given controlled release oxycodone and 1.1 for patients given immediate release oxycodone. This study concluded that cancer pain patients given 6 to 12 tablets of fixed-dose combination analgesics can be equally treated with controlled release oxycodone administered every 12 hours or immediate release oxycodone 4 times daily at the same total daily dose. Lastly, similar to the study in the last slide, this review investigated oxycodone and whether it is associated with better pain relief and tolerability than other strong painkillers for adults with cancer pain. They included 23 studies with 2,648 participants in their review and assessed each study. Each of these studies compared the pain-killing ability and side effects of different types of oxycodone to each other or to other strong painkillers. They came to the conclusion that oxycodone is an equally effective strong painkiller whether taken every 6 or every 12 hours and equally effective as other strong painkillers such as morphine. This study had the same conclusion as the study mentioned previously, and how from this it is reasonable to conclude that oxycodone is efficient in all forms and produces analgesic effects no different from other painkillers such as morphine. Overall, oxycodone is proven to be an efficient painkiller and produces analgesic effects no different from other painkillers. It is shown to be beneficial in all forms and is very helpful for pain management. While there has been thorough research regarding the efficiency of oxycodone in pain relief, much more research is needed to be conducted in regard to the pharmacology of oxycodone, as most of the pharmacological data has been from the 90s. Oxycodone abuse and addiction is becoming more and more prevalent in today's society as prescriptions keep increasing. The study regarding urban and rural users brings up the question of whether or not routes of administration has anything to do with prescription use versus non-prescription use. Seeing as most users take oxycodone orally, which is how most prescriptions are directed, and how most rural users snort oxycodone, which is known as an alternative route of administration, one can infer that illegal use of oxycodone is more prevalent in rural areas. Further research and data on this topic would be very beneficial to gain a better understanding of oxycodone abuse. There is now a medication called Narcan that is an opioid antagonist used to counter the effects of opioid overdose. The Monroe County Department of Public Health provides opioid overdose prevention training. Training is open to all who are interested and there is no cost. The prevention of opioid-related deaths is very important, and with many free trainings in the area, there are many great opportunities to get trained and help prevent opioid-related deaths. You can find more information regarding this training on the Monroe County Department of Public Health. Here's a list of my references, and I hope you all enjoyed my presentation. Thank you.